So just for an introduction, my name is Dr. Jayawickrama. I'm currently a second year general surgery registrar, currently working in the National Hospital of Sri Lanka. So today we are going to discuss about fractures and its principles. This is actually a small bulk of your entire ERPM syllabus, but this is a hot area where the examiners can question you with MCQs, as well as even you can gain cases like for example, they can show you cases for the short cases from this topic. So it is, even though it's a small topic, it's actually very important and should have a comprehensive idea about principles of fractures. So without much ado, we'll go into the lectures. And before we start the lecture, I just want to say that if you have any doubts or any questions, just speak up, because even if you just message, I won't be able to see it when you message. I might see it later on, but by that time we will be gone far from our discussion point. So if you have any question, just unmute the speaker, unmute the mic, and just please ask. This is a friendly discussion. Nobody is going to penalize anybody. No questions is every questions is valid and can be answered. Okay. All right. So she'll go to the lecture. So principles of fractures. In this lecture, we will start with introduction and classification of fractures. What is a fracture and how do we classify fractures? And then how do we evaluate a patient with a fracture if a patient with a fracture come to us in a ward setting? How do we evaluate the patient, and how do we manage the patient, and the principles of fracture healing? And then we regarding principles of fractures, and then we will finish the lecture. All right. So, first of all, what is the definition of an fracture? Fracture is when there's a break in the structural continuity of the bone. So when there's a defect or loss of a bone segment or discontinuity through a continuity of the bone, it's called a fracture. Why does fractures occur? There are two mechanisms why a fracture can occur. First is because there's an external force that is too much for the bone to handle. That is too much, so that the tensile strength of the bone is not adequate to handle that force, so it tends to break. The second instance is that the bone itself has been weakened by some consequences. The bone itself has been weakened. So a normal stress that normal people like you and me can handle, the disease, the diseased bone cannot handle that stress, so it tends to fracture. So those are called pathological fractures. So first of all, we'll talk about the fractures that is because of the external force that is not possible for the bone to handle by a normal bone. So it is usually due to an injury, like an external injury. It could be due to a direct force or indirect force. So what do you call direct force? Direct force is when the fracture is at the site of the application of the force. If you apply the force around here and the fracture is here, so it's a direct force. But if you apply the force around here, if you have and you have the fracture here, then it's an indirect force. That is, the site of the fracture is away from the site of the application of the force. All right. So, and one other mechanism where fractures can occur due to external stress is all repetitive stress fractures. For example, this is very common in people who, for example, in military personnel where they go march passing and they repetitively hit their foot to the ground. So they can have fractures in the talus. Small minute hairline like fractures that is due to repetitive stress. These are called stress fractures. So the other mechanism where bone can fracture is due to abnormal weakening of the bone, so that the integrity of the bone is compromised. So a normal stress that can be handled by a normal person is not being able to handle by this weakened bone. There are different mechanisms that can cause. For example, osteoporosis. It's very common in elderly females because after menopause, we know the estrogen protective effect from the estrogen for bones is lost. So it causes osteoporosis. So that even a normal, even a small fall can cause a trivial fall can even cause a fracture. Also, patients with osteomyelitis, where there's an infection in the bone marrow, which causes structural integrity, loss of structural integrity of the bone. It also can cause pathological fractures, as well as metastatic deposits from non-malignancies. If there's a bony metastasis from a malignancy, that itself can cause structural weakness because of the osteoclast activity. The calcium gets reabsorbed by the bone, so the bone gets weakened. So even normal stress can fracture this bone. Also in patients with primary bone malignancy such as osteosarcoma, chondrosarcoma, Ewing sarcoma, those patients can also get pathological fractures because in them also the structural integrity is lost. Okay, so that we have discussed how a fracture occurs. Now, how do we classify a fracture? Now, imagine you are a house officer and a patient comes with a fracture. Now you have logged the patient. Now you have to inform your senior, SHO, registrar, SR, or even the consultant sometimes. You want to inform the senior that this patient has this kind of fracture. How do you do it? You can't just say there's a patient with a fracture. Okay. First of all, we should identify which bone is fractured. For example, it could be a radius or ulnar fracture. It could be a humeral fracture, like that. Name of the bone of the fracture. Then region of the bone. You know, long bones have three uh, anatomical areas. For example, if you look at this picture, there are three. For example, the epiphysis, proximal, and the distal. And then comes the metaphysis. And the shaft is called the diaphysis. So according to the location of the fracture, we can classify it as a diaphyseal fracture of the femur. We could classify as a epiphyseal fracture of the femur. We classify the metaphyseal fracture of the femur. That is according to region of the bone. And then the type of the fracture line. The fracture line could be different types. It could be a complete or incomplete. As in the complete also, there are different categories, incomplete or different categories. So we will discuss it a little bit later. So according to the pattern of the fracture line, based on the imaging, we can identify, we can classify it again. And then, is there a degree of displacement? If the fracture segment is displaced or not? If it's not displaced, right, all right, undisplaced fracture, we can just say. But if it's displaced, how has it displaced? So there's a small mnemonic called STAR, STAR. We'll go into it a little bit in 2-3 slides. So according to the display type of displacement, we can again classify it. And after all the bone, there's a soft tissue covering of the bone. There is skin, subcutaneous fat, muscles, tendons, nerves, and vessels. So those also can get injured during a fracture. So we have to comment on those things as well. So that also we'll discuss in the next slide. So according to the region, as I said, it could be classified into epiphyseal, metaphyseal, and diaphyseal. Uh, and the metaphyseal fractures can be classified as extraarticular, partially intraarticular, completely intraarticular. For example, in young adults and sorry, not young adults, in children and adolescents, where the growth plate is still intact and the growth is still ongoing, the fractures involving the growth plate is classified in the Salt-Harris classification of physical fractures. You don't need to know this by heart, these types. If you just know that fractures involving the growth plate can be classified as Salt-Harris classification, that is more than enough. You don't need to by heart it. Just know that there's a classification called Salt-Harris classification for fractures involving the growth plate. That is enough. So this is the anatomy of the bone, which we discussed. And the pattern of the fracture line. The next step to of classification. It could be complete or incomplete. Complete is the bone is completely fractured. There are two segments. Incomplete is there's no two segments. The bone is has some continuity between the two segments. In complete, there's no continuity. In incomplete, there's some degree of continuity. So complete fractures, we can classify according to the fracture line. Fracture pattern, we can classify into transverse fracture. So basically the fracture is transverse like this. Spiral fracture is rotationally. For example, rotational forces applied on a bone, it can cause spiral fracture. Oblique fracture, you can like in a diagonal way. Impacted fracture, the fracture segments has separated, and then due to external force, those two segments has impacted together. And then segmental or comminuted fracture. The comminuted fracture, this is a very important term, is where there is more than two bony segments. For example, there's a bone has fractured and another small piece has come out like that. So there's two segments. So that means it's a comminuted fracture, more than two segments. So you can see these are images of type of fractures, where it's oblique, as I said, undisplaced displaced oblique, and undisplaced oblique, transverse fracture, linear fracture. This is not very common. Comminuted fracture, as I said earlier, spiral or rotational fractures, and segmental fractures. Difference between comminuted and segmentally, the segment is large. In comminuted, it's just bone pieces, small pieces that isn't fractured into. But in segment, there's entire bony segment. For example, as you can see part of the bone shaft. Shaft has come off. So it's a segmental fracture, contrast to comminuted fracture. Okay. So anybody have any questions up to now? Or any clarification? Any questions? No. Nothing in the chat group. Okay. If anybody has any question, just raise your voice and ask. No problem. So next is incomplete fractures. Incomplete fracture is where the bone is divided into two segments, two or more segments, but the continuity is not completely lost. One part is still hanging on. You can see in these images. One is a green stick fractures. So you can see part of the periosteum is breached, but the other part is not breached. It's still intact. This is usually seen in children because the plasticity of the bones in children are still high because of they have not completely ossified. So they are still a degree of fibrocartilage element. So it doesn't fracture like in adults. It's called green stick fracture because I'm sure most of you have tried to break raw branches. I don't know. In that case, you must have noted that when you break it, the opposite side where you apply the force will break, but the other side, the bark won't break. To separate the bark, you have to twist and take it off, and something you have to have something else to take off. But just by the force, the bark on the this side will be intact, but on the opposite side, it will be fractured. That's why called green stick fracture. Very common in pediatric population. And others is torus fracture. Torus fracture is where, for example, torus is where you must have seen in pillars. In pillars where in the lower side there are like knobs. That's called torus. For example, you can see in the image the two segments has compressed into each other, causing a torus. This is common in vertebral fractures. Okay, and then whether the bone is displaced or not. Undisplaced fracture, a displaced fracture. A displaced fracture can be classified into depending on the degree of displacement and type of displacement. It's called, there's a short mnemonic called STAR, STAR. S means shortened or length. Basically, the fracture segments are separated or shortened, like in a torus fracture, impacted or separated. Translated, the bony fractures has translated to each other in a horizontal plane. The bone is like this, long bone is like this, is translated. Angulated, the bony segment is like this. Bone segment has angulated and rotated. Bony segment is rotated, rotated because of rotational external forces. So that is how you classify a displacement of a fracture segment. Okay, so you can see the images of fracture displacement, rotational, angulated, translation, and shortened and impacted. This is impacted and this is lengthened, for example, in patellar fractures. Okay. And then we talk about the soft tissue injury compartment. If the soft tissue is breached, that is called a compound fracture. If it is not, if it, for compound fracture means usually now when a fracture occurs, there's bleeding within the two segments. There's a hematoma formation. Fracture happens, there's a hematoma formation. If this hematoma is in communicating with an epithelial surface, it could be skin, it could be a mucosa. If it is communicating with the epithelialized surface, that is called a compound fracture. Did you get the idea? Did I confuse you? Okay. I hope it's clear. Just to say, summarize again, when the fracture occurs, there's a small hematoma. Hematoma occurs. If this hematoma is in communication with the breach of an epithelial lining, either skin or a mucosa, then it's called a compound fracture. Compound fracture does not occur only in the long bones. It can occur in other areas also. For example, pubic bone fractures can lacerate the vaginal mucosa or the rectal mucosa and cause a compound fracture. That is possible. And a mandibular fracture can pierce through the oral mucosa and cause a compound fracture. That is a possible. So it is some kind of epithelialized lining. Okay. And I told you there's other associated structures, muscles, nerves, tendons, and vessels. So those can get injured. For example, the fracture segments are sharp, a nerve or vessel can get lacerated. So we have to comment on the distal neurovascular injuries. And when this force is extreme, apart from the fracture at the point of impact or at a different area from the point of impact, there could be associated joint dislocation or subluxation. There's associated fracture as well as a nearby joint subluxation and dislocation. We should comment on that also. So as I earlier said, compound fracture. There is a classification called Gustello-Anderson classification. That's how we classify compound fractures. You don't need to know by heart these fractures. You don't need to by heart. You just need to know that there's a fracture. There's a classification like this, and there are 3 grades. For the completion sake, grade 1 is when the length of the wound is less than 1 centimeter. Grade 2 is between 1 to 10 centimeters. Grade 3 is when it is more than 10 centimeters. And grade 3 also can be classified into 3 categories: A, B, C. A is when even there's a wound of more than 10 centimeters, it could be approximated. In grade 3B, there's a loss of tissue and the wound cannot be approximated. So there's a defect. The bone is open. And 3C is where there's an arterial injury, vascular injury that needs intervention. So just know that there's a classification criteria called Gustello-Anderson classification that is used to classify open compound fractures. That is enough. Okay. So up to now, everything clear, or do you need anything like re-explained again? Anybody? Okay. Okay. Now that imagine now you are a HO in the ward, there's no accident service. Straight away the patient comes to the ETU, and from the ETU, they send the patient to the ward, and they are coming and telling you, doctor, I feel my arm hurts. So how do you evaluate a patient? So the patient can present in different ways. The patient can present in a clear conscious state, or the patient can present to you in an altered conscious state. For example, a patient, drowsy toxicated patient, or the patient may be having multiple other injuries, for example, head trauma, that the patient cannot explain him by himself what has happened to him. Patient is basically unconscious. So depending on that, if the patient is conscious and this is an isolated injury, we should take a detailed mechanism of the detailed history of the mechanism of injury, how it happened, when it happened, what type of force, with what injury, with what weapon or with what object the injury was happened, how you was positioned when the injury was happened. All these details are very important in making a diagnosis, if possible. And we should also anyway, we will know the sex of the patient, and the age of the patient is important, and the site of the pain, and if the patient is communicating about some deformity he has noted, and swelling. And if the patient is not conscious and there is a bystander or a paramedic, we should take a short history to get a good idea about what has happened. That is called an ample history. A for allergies, M for medications he is on. For example, the patient may be on anticoagulants such as clopidogrel, warfarin. That may be important if you are going for surgery. So, a history about medication. That that detail may be known by the relatives or the paramedics or not, but that's all right. We should ask for it. And the past medical history, whether this patient has had any other comorbidities like ischemic heart disease with low ejection fraction, then it again is a contraindication for surgery. We should know this. And the last meal, because we know patient needs to be fasting for 6 hours for solid materials. Otherwise, there's a risk of aspiration. But saying that in emergency cases, we have to do it. There's a special way of giving anesthesia so that the aspiration does not happen. But we should know that whether this patient has had a last meal before 6 hours of duration, and liquids before 2 hours, and events leading to the injury. Basically, what happened? For example, this patient might be riding a bicycle and then impacted the road, the mile post, and fallen and hit the arm, and maybe having a fracture. So what happened? How fast were you going? Is it a high velocity? Where did you impact? What did you impact? So those are important. For example, if he impacted a contaminated surface, there could be contaminated material in it, in the wound. So it is important to identify the events leading to the injury. That will help us in formulating a management plan. And also we should evaluate any features of neurovascular injuries. The patient must, maybe if there's a neuro and nervous nerve injury, the patient will be having paralysis, paresthesia. And if the patient is having vascular injury, the patient will be in extremely ischemic pain, as well as cold and pale limbs. So that is the history. Then comes the examination part. Examination, as I said earlier, I know that we have not discussed about the ATLS guidelines, which we will in later presentations. In the ATLS, ATLS called Advanced Trauma Life Support. The approach to a traumatic patient is called ABCDE approach. That means airway takes priority before breathing, breathing takes priority before circulation, circulation takes priority before disability and nerve disability and head injury, and then comes exposure. So even the patient comes with fracture, we should exclude ABCD and then comes to fracture, because excluding fractures is in the secondary survey of the ATLS, not in the primary survey. We will discuss about this in ATLS lectures. So just have an idea, initial ABCD evaluation is necessary before approaching the fracture. And then once the primary survey is completed and the patient is deemed to be not in any life-threatening condition, then we go to secondary survey, where we evaluate the patient from head to toe and front to back, and evaluate the fractures. In evaluating the fractures, we can look for signs, feel for signs, and move for signs. Okay, we look at the whole limb, entire limb, and we should compare with the other limb also. We should look at the entire affected limb and the other normal limb also we should compare with, because the patient may be having congenital skeletal deformities that we may take as fractures. So that could be bilateral. So if this bilateral deformity, unless there's a history of trauma to that side also, could be congenital. We should exclude it an X-ray and look front and back both, compare with the other limb, and look for external injuries, bruising, any deformities, swelling, wounds. If there's wounds, take photographs, and with definitely with consent for later communication with other team members. And you don't have to take the dressing again. So you can have you do have a photo about the wound, and you can formulate a management plan without taking the dressing off. So and then look for the color of the limb. The limb would be pale. If there's an arterial injury and the distal blood flow is cut off, the limb could be pale. Oh, then we will feel the with the patient's consent, and without causing much distress to the patient, we gently feel. Look for bony tenderness. Whether the impact area when we palpate the bone, is it painful? If it's painful, stop. If the degree of swelling, look for capitis. There could be subcutaneous air. For example, delayed presentation of fractures can now come with gas gangrene. There could be capitis. Look for it. And the neurovascular examination. We should look for distal pulses. With the distal pulses are palpable. The capillary fill time with the capillary time is less than 2 seconds, and the temperature, and as well as saturation. We should can check the saturation of the fingers and toes, and for nerve injuries we can check for sensation and motor power. One thing to highlight in this topic is, even if the patient has a good distal pulse, when you examine, if the clinical condition changes, we have to repeat the examination, because the arterial injury may not be evident at this moment. It could be evident in the time later on, because there could be injury and there could be injury to the tunica intima of the vessel, where even though there's no laceration in the vessel, there could be a clot forming. With the clot forming and propagating, and when the clot completely occlude the vessel, it could cause distal ischemia. So that when you have examined the patient at the first time, it might not be there. But if you examine in patient in 1 or 2 hours, then it might be the features of distal vascular compromise. So we should do it is important to know. Repeat interval examinations might be needed. This could be an MCQ point. Okay. And then feel for active and passive movements without causing much distress. Look for active, whether the patient can actively move the joints proximal and distally, and passive movements. Okay. Then we come to the investigations in the evaluation part. Investigation for fractures, the primary investigation that we go for is plain X-ray. When you take an X-ray, there are some principles that we should abide by. Every X-ray that we take for fracture should be done by 2 views. That is, we view from one degree and from another degree, 2 views. And this view should include 2 joints, one above the fracture, one below the fracture. So as I said earlier, 2 views. You can see this X-ray. The army, it's X-ray of a hand. There's an anterior-posterior view and a lateral view. So this, for example, this is one of the pictures that I have seen during my days as an undergraduate. The lion carrying a cub. So you can see from one image, it seems that the lion is basically eating the cub. But if you take an image from the other side, you see that is not the case. The lion is actually carrying the cub, not eating the cub. So this is a good picture to demonstrate to you that 2 views is absolutely mandatory rather than 1 views. I just put it because it's a funny picture, and I also has been impressed by that. Okay. So and two occasions, and sometimes the initial X-ray done at the time of the injury may not show a fracture. Small hairline fractures will not be shown in the X-rays. But if you give time, 1 or 2 weeks, and you do a repeat X-ray, if there's features, clinical features suggestive of fracture, then there will be a callosity formation. This callosity will be detected by the X-ray. So a repeated interval X-ray might be needed. For example, it is scaphoid fractures. Scaphoid bone in the carpus of the hand is notorious for these kind of fractures. So this typical effect. They are usually not detected in the initial X-ray, but if you repeat in 1 to 2 weeks, then you will see the callosity. Callus formation. Sorry, not callosity. Callus formation, and we can be seen in the X-ray. And especially in children, we should X-ray both limbs, because it is very common to mistake growth plates as fracture lines. So we should X-ray both limbs to evaluate, to compare and contrast. Other forms of imaging, such as computer axial tomography, or CT as given by short name, it gives a multi planar 3D image of the bone, and we can get reconstruct a 3D image of the bone and see the fracture segments, and it gives us a good anatomy of the injuries. And if there's associated vascular injury, then we can do a contrast enhanced CT and detect the vascular enhanced, that is contrast angiogram, and do a angiogram CT, get an idea about the vascular anatomy, and where the injury is. And there's a chance for magnetic resonance imaging also. If there's a clinical suspicion of fracture and the X-ray and the CT is equivocal, then there's a chance for magnetic resonance imaging, and it gives a good idea of the soft tissue damage. For example, in a fracture involved in the knee joint, and we know that there are some ligaments, then we can do magnetic resonance imaging where it would be clearly shown. These are just hi-fi. You don't need to know why it is done. If you know that MRI can be done, computer axial tomography can be done, and the plain X-ray is the primary most important X-ray form of imaging, that is enough. Okay. So before we go into treatment, now we have the patient has come to us, we have evaluated, we have come to a diagnosis. There is a fracture of this kind. Now we are going to management. But before we go to management, we should have an idea of how the bone heals. Without idea of how the bone heals, we can't manage the fracture. So a bone healing can be categorized into two types: direct or primary bone healing, or secondary, indirect bone healing. The difference is, in direct bone healing, the fracture segments are completely approximated together and is tightly fixed. There is no micro movements in between. Basically, the bone segment has reapproximated again. So there's no the hematoma formation in between is very minimal, and there's no micro movement. So the callus formation, soft callus and bony callus formation is very minimal. It just heals on its own. No callus formation. This has some advantages and some disadvantages. In some occasions, for some fractures, direct bone healing is good. For example, fractures involving the articular surfaces, we need direct bone healing because we don't need to make a callus in an articular surface. That will cause joint mobility issues. But in fractures involving, for example, fracture involving the femur shaft, we don't need the primary bone healing, because primary bone healing, the structural integrity achieved is not very good. The secondary bone healing gives you good structural integrity once the bone healing occurs. So on that, for example, for femur shaft fractures, we need secondary bone healing. So secondary bone healing or indirect bone healing is when there's a small gap in between. There's a small gap, not a massive gap. The bone ends are approximated, but you can see a small 2-3 millimeter gap, 1-2 millimeter gap between the bones, and where there's a small hematoma formation, and this hematoma will promote inflammation. Inflammation will promote fibroblast formation and cause soft callus formation, and with the soft callus formation, the calcium deposition will cause a hard callus formation, and with the hard callus formation and with the mobility, the bone gets remodeled and heals back to its normal state. So as I said earlier, this has some advantages, some disadvantages. Some fractures, this is advantages. Some fractures, these disadvantages. For example, in fractures involving articular surfaces. Okay. So how does a bone heals? If all the conditions are ideal, the two bone ends can heal completely. Is called union. Complete union. Bone fragments has healed. But when the conditions are not ideal, when there's infection, when there's associated soft tissue entrapped in between two fracture segments, when the fracture segments are not opposed correctly, there's a degree of displacement, then it can cause malunions, such as either can cause delayed union, non-union, or malunion. Delayed union is the time taken for healing is much more than we have expected in a normal person. Non-union is when it never heals. It just stays like this and it never heals. Malunion is there's some degree of healing, but it's not complete, and there is associated deformity. That is called malunion. So up to now, everything clear. I just want to ask again. If there's any doubt about what I have said up to now, you can just speak up. Anybody? No, right? Okay. Then we'll go to the treatment. When we talk about the treatment of fractures, there are 4 principles. First, if there's a dislocation, we should reduce the bone. If displacement, we should reduce the bone, because if it's displaced like this, it never heals. We should reduce, and once it reduces, it can always replace dislocate again. So we should hold it, reduce and hold it for the bone to heal. We basically hold the bone ends together. So you tell the body, okay, you heal. We will hold the bone ends together for you, and then the body heals. Once the healing is complete, we do the rehabilitation of the limb. So that is the main principles of fracture healing. Very simple. No rocket science. If it displays, reduce, hold, let the bone segments heal, and then rehabilitate. Okay. So our objective is to return the patient back to his functional position as much as possible, as soon as possible. So if there's associated large segmental loss, then we have to return to the patient as much as possible. We might not be able to return the patient to his full functional position, but as much as possible, we should try to gain, and as soon as possible. Okay, reduce. So to gain adequate positioning, to reduce the bone so that it stays in the normal anatomical position for the bone ends to heal. This can be done by several methods. These are MCQ points, so pay good attention to this. Reduction can be done by either open reduction or close reduction. Open reduction means we surgically enter through the soft tissue to the bone and manually reduce the bones together. In close reduction, we do not open the skin and go to the bone. We manipulate the bone outside with the guidance of X-ray images. That is called a C-arm image. With those X-ray images, we manipulate and guide the bone. We take serial X-rays and see. We guide it a little bit, take an X-ray and see whether it's approximated. Okay, no, we guide it again, little bit again, we guide it, and then again see whether so once the approximation is adequate, then we can hold it in that position. This can be done either manipulation and anesthesia. So this is extremely painful. So we need anesthesia. So we give anesthesia for the patient, and that causes muscle relaxation also. So it's easier for us to manipulate. For example, after fracture, there's a lot of pain, lot of inflammation. This causes muscles to go into spasm. So we might not be able to just manipulate the bone. So we have to give anesthesia. We have to paralyze the muscle. After that, we can stretch the limb, and we can manipulate it. And other type is by traction. We basically apply distal traction to the limb. By that, the ligaments of the bone will guide the bone ends together. With the traction, the ligaments will guide the bone ends together. That's called traction. It's by that ligament pull is called ligamentotaxis. Okay. Just to show that there are different forms of traction. So this is skin traction. So basically, we hang a weight to a wire, and then we fix it with plasters to the skin. It's called skin traction. And skeletal traction is where we insert a pin through a bone. For example, in this patient, the pin has been put through the tibial tuberosities, tibial epicondyles. So, and then weight has been added. So the that pull that pulls the fractured femur shaft, and it aligns together. So skin traction and skeletal traction. I just want to show you the images. Okay. And then hold. How to hold? We have reduced it. Now we have to hold, otherwise it will again displace. Hold. There are different methods. Again, traction. We can continue the traction. That traction we applied, we can continue it. Then it will keep the bone ends aligned. That's fine. We can also use plaster of Paris cast. The commonest thing we use is plaster of Paris cast. I know you all of you have seen it. Some of you must have even worn it if you had any fractures. And then internal fixation and external fixation. Those are the 4 methods. Very simple. So continuous traction can be either skeletal traction or skin traction. And I forgot to mention, sometimes the traction can be held by gravity itself. You can basically let the arm hang over the bed. The gravity itself acts as a traction. But saying that, this has disadvantages. Sometimes there could be radial nerve palsy. So we should do it with caution in selected cases only. But traction by gravity is also an option. But you don't need to know the complications. The what I said, the radial nerve complication, for example, in traction of the upper limb, that is enough. If you know there are these types of traction, that is enough. You don't need to go into details. And skin traction, the maximum we can apply is 5 kilograms. Beyond that, it won't be effective. The plaster will basically come off. Okay. So what are the advantages of traction? It is cheap, very cheap. It could be easily done in the ward. You just need the weight and a cord and plasters. And orthopedic help, orthopedic intervention to put a pin if it's skeletal traction. And it's adjustable. We can add on more weight. If the weight is not enough, we can add on more weight. And it doesn't involve the fracture site. We pull from a different area. The fracture site is not, we are not touching at all. We just pull from a different healthy area. So the fracture site is open for other treatments. For example, if there's a wound, we can easily treat the wound. But there are also disadvantages. Nothing is perfect. It restricts the mobility. The patient is basically bed bound. The patient can't move because the traction is there. Patient can't move. He will be on the bed. And this will again lead to prolonged hospital stay that cause a financial burden to the hospital, the health sector, and the patient's household also. Maybe the patient will be the sole breadwinner, and it causes financial burden for prolonged hospital stay. And as you all know, when a person stays in the same position, there's a risk of pressure ulcers in the trochanteric areas, sacral areas, in the scapular regions, head, heel, you name it. There's a risk of pressure ulcers. And if it's a skeletal fraction, there's a chance of developing pin site infections. About less than 5%, but there's a chance of pin site infections. Now, this is the common, very important what? Plaster of Paris cast. You can see a photo. The type of plaster, depending on how the plaster of Paris cast has been applied, there are different types. A full POP. The plaster of Paris is basically wrapped around the entire circumference of your limb. So that's a full POP. It could have a window or without a window. This can come in your short case. They can show, examiners can show you a plaster of Paris cast and ask you to comment on it. You should be able to identify the cast and say this is a full plaster of Paris cast with the window, if there's a window. Why do you make a window? Window is there's a small hole in the plaster of Paris cast used to do some intervention or examine the patient. It could be to check the distal pulses. For example, in a lower limb plaster of Paris cast, there could be a small window over the dorsalis pedis artery, so we can easily check the pulse, which is important in compartment syndrome. And then if there's associated wound, to treat the wound, if you put a POP over the wound, then you will be able to treat the wound. Whenever you remove the POP only, you will be able to treat the wound. By that time, the wound will be infected. So in order to treat that wound, we make a window over the wound, so we can easily access the wound and do dressings. So this might come in an exam setting, as a short case. So you should be able to identify. And then the full POP is actually going out of style now. It's very rarely we see. For I must have seen for my last 1 year, maybe 1 or 2. Very rarely they are putting for selected circumstances only, because of the risk of compartment syndrome. We will come to what compartment syndrome later on, just to have an idea. So what is most in favor now is back slab. Basically, we put a POP slab, back slab or front slab. POP slab, actually, not back slab. It could be back or front. It's basically POP slab. Sorry for the typo. And this could be a 3/4. If we need more stability, it could be a 3/4 step. Now, for example, we know in the arm there are 4 surfaces: posterior, anterior, medial, and lateral. So 3/4 is of the 4 surfaces, 3 surfaces are covering. For example, a back slab with wings in the lateral and medial side, basically like this 3/4 slab. And there are other types such as U slab, for example, in fracture fracture of the shaft of humerus, U slab from the shoulder up to the forearm. So U slab, and other cause are POP boots, which is going out of style for malleolar fractures. So the aim of the plaster of Paris cast is to immobilize the joints, immobilize, hold the fracture segments that has been reduced, and immobilize the joints, the proximal joint and the distal joint, so that the movement is minimal, not complete lost, but minimal, very minimal, to promote secondary healing. So if you apply a POP cast, for example, you are the house officer. Now you are doing a general surgery appointment in, let's say, Vatupidiola, and the patient who came with fracture shaft of tibia now comes with, has gone to the theater. Now they have put a plaster of Paris, full POP, full low 3/4, and then transferred back to your ward by the orthopedic team. Okay, now what should you now we have reduced and hold it. Now what are you going to do? We should monitor this patient, because there's a chance of developing compartment syndrome. Okay, what is compartment syndrome? Compartment syndrome is when there's for example, you must be remembering from your anatomy days, the muscular there are muscular compartments in the limbs. For example, in the in the shin, there is 4 compartments: anterior, lateral, and posterior, superficial, and deep. Like that in arm also there is compartment, anterior and posterior. And anterior one, there are superficial and deep compartment. So those are important. So with these compartments, if there's a fracture, there's a response, inflammatory response. In this inflammatory response, there's swelling. This swelling inside a tight compartment. For example, now you fill a balloon with water and then you compress the balloon. And when you compress the balloon, the pressure inside increases. It's like that. In the compartment, when the edema increases, the pressure increases. When the pressure increases, it can hamper the neurovascular status. For example, it can cause vascular obstruction, vascular compression, and it can cause damage to the nerves. So that is called compartment syndrome. Pressure developing in compartments of extremities. Remember, compartment syndrome is not exclusive for extremities. It can occur in abdomen also. There's a specific entity called abdominal compartment syndrome. Just don't confuse. But in this lecture, we are talking about compartment syndrome in extremities. Okay. So did I confuse you? Did you all understood what I said, or did I confuse you? Okay. Any messages? I know most of guys doesn't want to talk, so no messages. Okay. That's clear, sir. Yeah. Okay, thanks. Super. So got the idea, right? So to define compartment syndrome is a clinical diagnosis, but actually the definition is the pressure in the compartment is 30 millimeters mercury more than the diastolic blood pressure. Okay. Okay. Sorry, I'm sorry, my mistake. The not the not more than the pressure difference between the diastolic blood pressure and the pressure in the compartment is less than 30 millimeters mercury. Extremely sorry for my mistake. I hope this doesn't confuse you. So again, I will explain it. The pressure difference, the pressure inside the compartment and the diastolic blood pressure. If you take the diastolic blood pressure and minus it from the pressure within the compartment syndrome, it should be more than 30 millimeters mercury. If it is less than 30 millimeters mercury, then compartment syndrome is there. Got it? I hope it's clear. I hope I didn't confuse you. Okay. If we diagnose compartment syndrome, this is an emergency. We should intervene exactly then and there. Now, the orthopedic medical officer has put an POP and sent to the patient the ward. You might be thinking, okay, if I remove the POP, the orthopedic MO will come and scold me tomorrow. No, it's compartment syndrome. You should urgently bivalve the POP, full POP, the POP cards. What is bivalving? Bivalving is cutting through the entirety of the POP cast up to the skin. So the entire POP should be divided full length from distal to proximal, entire length down to the skin. So basically, it bivalves. That's called bivalving. We incise it on the top. So it's basically bivalving, and the leg is and the skin is exposed. Okay, that is the initial management, but that doesn't end up there. Okay. Okay, we'll just talk about how we diagnose compartment and then go to the management. So there are 5 P's. Easy to remember. 5 P's in compartment syndrome. First is pain, excruciating pain out of proportion. For example, it's a simple tibial fracture, but the patient is basically howling in the ward, saying every bad word and howling in the ward and cursing you and us, everybody, because that extreme pain because of the compartment pressure, extreme pain. And if you try to passively stretch the flexor muscles, then it causes extreme pain because the inflammation involved and the edema. If you tend to extend the flexor muscles, then it causes extreme pain. That is the first sign in compartment syndrome. And then paresthesia. Paresthesia is due to now the nerves have their own small vessels, blood vessels. With the rising compartment pressure, these small vessels get compressed earlier than large vessels. So when these small vessels get compressed, the blood flow to the nerve gets compromised, and this called ischemia to the nerve, and that caused that affect the function of the nerve, causing paresthesia of the limb. For example, in this patient, tibial fracture, if he develops compartment syndrome, the paresthesia will initially occur in the first web space because of the involvement of the deep peroneal nerve. Deep peroneal nerve supplies the first web space, and it goes through the compartment, and it can get compressed easily in compartment syndrome in early stages. And then paralysis with the with the further involvement of the nerve, even the motor compartment gets affected, and it causes so there's a message. So can I say that the compartment syndrome is due to a tight POP cast? Compartment syndrome is not due to tight POP cast. Compartment syndrome is due to the injury, associated edema due to the injury. But keeping a tight POP cast over and area with compartment syndrome, it's going to get, the pressure is going to exponentially increase, because the skin can stretch, but if we don't give it space to stretch, then the pressure will exponentially rise. Did you get the idea? It is not because to tight POP cast. Do you understand what I said? Marine, I think Marine message. Yeah, okay, good. So yeah, I was telling about paralysis because of with the progressive ischemia to the nerve, the motor segments, so motor supply also get affected, and this then cause muscle paralysis. And then at the last stages, the vascular, the arteries get affected. It causes pale. Distal arterial blood flow is reduced, compromised, so the limbs becomes pale. And pulselessness. We cannot feel the pulse. As I said earlier, if you remember, in the full PO, because there will be sometimes there will be a window over the dorsalis pedis where we can check the pulse. So that is for that pulselessness. The pulse will be absent if there's a compression. If there's a compression above, for example, if you put a tourniquet to the arm and inflate the distal radial pulse, you won't feel like that. Compartment, say basically same principle. There's high pressure, reduce the arteries get compressed, no blood supply down, so no pulse, no paler and paler. So these are the 5 P's. Very simple, very easy to remember. If you know this, you are done. You are satisfied. All right. So we have now we have bivalve the POP cast. So okay, good. Now does that ends there? No. Even we have bivalve, the skin is still there. Skin again is skin, and the compartment, the fascial compartment, the fascia, they also are barriers for the expansion. So we should release those also. That is called a fasciotomy, and this fasciotomy is urgent. There's nothing called api kala innang ehama katha naha. We have to do it then and there. Inform the seniors, take to theater, do a urgent fasciotomy. We should release all the compartments. For example, you have seen, there's a photo I have provided for you, image of a fasciotomy done. You can basically see the muscles. The muscles are basically exposed. So this is a proper compartment fasciotomy. And there's a cross-sectional images also. For example, this is a cross-sectional image of the tibia-fibular region, where you can see the anterior, lateral, and the posterior compartments, the posterior deep and the posterior superficial. All 4 compartments can be released. Here, one anterior released, lateral is released, and from the medial side, the posterior compartment of the deep compartment of the posterior compartment and the superficial compartment of the posterior compartment is released. So all fascia is opened up. So when the fascia is opened up, no matter how much edema develops, the muscle can just bulge out. So the pressure developing inside is less. You got the idea, right? You got the idea of the management. That's called urgent fasciotomy. This is an emergency because you might be the only person in the ward in a 24-hour basis, and you might be the only person who will be able to recognize this. So if you don't recognize this, then it will be a problem. The ischemia can cause this ischemia even can lead to amputation. So this is very important, not for the exam itself, but for the exam it's important. In your clinical practice also, this is very important. You should know this if you are doing a surgical specialty. Okay. After the POP, and this is not about compartment syndrome, sorry for the typo. So after we have, now imagine there's no compartment syndrome, we have put the POP and send the patient to ward, no compartment syndrome. So what should we do if there's no compartment syndrome? We should take an repeat X-ray to check if we only did it under C-arm guidance. C-arm guidance is not very good for and it doesn't have documentation purpose. So we should take a X-ray to as a documentation and find properly. And if it's not real and properly, and we should again manipulate on anesthesia or go for an open reduction, we should manipulate again. Okay. And then once the POP has applied, start the physiotherapy. So what are the advantages of POP cast and the disadvantage? It's very cheap, easy to apply, very cheap and adjustable. If it's if one POP cast is not, we can just take it off and put another, no problem. And it does not interfere with the fracture site. There's no interfere with the bone. It's just over the skin. So the bone is not involved by the POP cast. It's just it stabilizes it, but it's not involved in the bone. And the disadvantages is, sorry for the typo, the risk of compartment syndrome should be going to the disadvantages. Sorry. So disadvantages are risk of compartment syndrome, and if there's associated wound, as I said, if there's no window, then access to the soft tissue is less. There's a difficulty in accessing soft tissue and cumbersome. And some of you must have had POP cast in your lifetime. So you know it is very heavy and very difficult to manage, and you will be somewhat hampered in your day-to-day activities with the POP cast. And it interferes with function. You might not be, if imagine if you are having a large POP in your dominant hand, you might not be able to do your day-to-day functions as you used to do. It interferes with your function, your job, your day-to-day activities, and you might need somebody's help for your day-to-day activities. And with especially in elderly people, if we keep the POP cast for longer periods, it can cause joint stiffness and muscle wasting, because we immobilize the joints, the muscles are not working properly. It causes muscle wasting, and the joint tends to get ankylosis, joint stiffness, because of the prolonged immobilization. Because of that, POP casts are not kept for long periods in adults, in older people. And even if we put up, if preferred, if possible, we go for other methods of fixation rather than POP cast in elderly. Okay. So what are other methods of fixation? Internal fixation and external fixation. What is internal fixation? We basically go into the fracture, go into the bone, and we fix the bone then and there. External fixation is we fix the bone through the skin in an outside method. So types of internal fixation we'll discuss in a short bit. So what are the indications for internal fixation? Needing operative surgery. If there's imagine now we can't reduce the bone, we have to go, we are going for open reduction. If you are already going in for an open reduction, might as well fix it inside and come. So needing operative interventions, we will go for internal fixation. Unstable fractures where external fixation and POP cast will not do the job, then we have to go for internal fixation. Pathological fractures, because they are already weak, they are more prone to get damage, and external fixation and POP cars are not stable enough to hold it. So we will need to go for internal fixation. For example, vertebral fractures, we need to go for external fixation. Fractures that unite slowly. Example, femoral neck fractures. Or having difficult to mobilize, if you apply external cumbersome externally fixed settings and care for the patient. If it's internally fixed, then it's easy. It's basically the normal limb. We can just easy to move for the nursing and caring staff. So these are the types of internal fixation. There are nails and plates. You can basically apply a plate and fix it with nails. So the plate acts as a stabilizing holder, and screws and Kirchner's wire. So these are examples for intermedullary. This is an intermedullary nail going through the humerus shaft, and this is K wires, Kirchner wire, and this is plates fixed with screws. You don't need to know much details. If you can identify a plate, a K wire, a nail in an X-ray, and say this is fixated with it, that's enough. And just know that there are this is in methods, and just know the indications. You don't need to buy hard, just know what is internal fixation used for, and what are the contraindications for internal fixation, which I will explain in the external fixation. Okay, complications of internal fixation. Obviously, we are putting a foreign material into the body. There's a chance of surgical site infection, and there's implant failure. Sometimes the plate might not be able to handle the entire stress of the body, and it can fracture. The plate itself can fracture because of the entire stress, because it will be holding the entire stress of the body. Imagine if there's a plate fixation in the lower limb, and we have to walk, then the entire force gets concentrated on that plate. It can fracture, refracture, even after plate screwing, plate fixation, internal fixation, it can refracture, the bone can refracture again. Non-union. For fixation, sometimes we have to strip a long segment of periosteum. We should expose the bone to fix. For by exposing the bone, we might be cutting off the nutrient arteries to the bone. If you can remember that image I showed you, the anatomy of the bone, there are nutrient arteries coming to the bone. And if we strip the periosteum for long distance, the nutrient arteries can get cut off. And that will interfere with the bone healing. Less blood supply to the bone, less healing. So non-union, delayed healing, delayed union can occur. Those are the complications. Very simple. External fixations. What are the indications? Compound fractures. Basically, as I said, the fracture hematoma is in continuous communication with the epithelial lining. So it is exposed to the external environment. There might be already contamination there. We can't go and put the internal fixation, because why? There could be an already existing infection there. If you put a plate and come, it will get infected. High chance of getting infected. So that is absolute contraindication for internal fixation. Compound fractures is a contraindication for internal fixation. So remember that will be an MCQ point. Okay. And as a damage control method in patients with severe other injuries. For example, the patient comes with severe life-threatening other injuries, and there's also a limb fracture, and the surgical team is taking the patient to the theater for laparotomy. In that time, you are not going to go and put a plate. Either you can use a POP, or you can use an external fixator, which is easy and which is easy to do as a damage control method. We just fix it for the time being until the patient stabilizes. Then later on, we will take to theater and do the definitive management. Just a damage control method. Okay. And as a limb lengthening process, sometimes fractures will be associated with bone loss. For example, there's a fracture and the part of the bone is not there. It might be where the injury has occurred. It is no longer viable. It's there somewhere in the dirt. So it's not there. So we can use external fixate as a limb lengthening process. We can basically fix a external fixator, and we can basically as an interval method, we can just basically approximate and the limb lengthen. You don't need to know in detail what limb lengthening is. Just know that we can use external fixation for limb lengthening process. You don't need to know into detail. You can use that for it. And for infected fractures, as I said earlier, if there's infection ongoing, we can't use internal fixation. Okay. Types of external fixation. This is important for your short cases, because sometimes in exam short cases you will be given an external fixator and you will be told to comment on it. Okay, examine the patient and comment on it. So you need to tell what kind of external fixation. Basically, you need to tell is the external fixator is unilateral or bilateral. For example, if you take a limb, if an external fixator is applied on the lateral side, it's a unilateral fixator. If an external fixator applied in the medial side, it's again unilateral. But it is applied in both sides is bilateral. Okay, I don't understood. And planes, whether it's in one plane. For example, if you see this second image where my cursor is, you can see there are two planes. One, the above one in one plane, and second one is another plane. Basically, one plane like this, another plane like this. So the two planes, it could be either unilateral to biplanar, bilateral biplanar. It could be uniplanar also. So classify it as unilateral or bilateral, uniplanar or biplanar. That's all that you need to know. And sometimes it could be multiplanar. Sometimes some are triplanar and multiplanar. Right? So if you know these three things, that's enough for fixators. And you need to for in short cases, you need to examine the patient. You need to examine the general status of the general look, and whether the patient is septic and all. And then we have to assess the adequacy of the external fixator, whether it's strong enough to hold the bone, whether there's pin site infections, whether there's soft tissue loss and soft tissue defects, whether there's distal neurovascular injuries. We should also check on those in examination of external fixator, but we will come to those in later stages in our clinical in Viva setting. But for time being, you just need to know there's unilateral and bilateral, or uniplanar or biplanar or multiplanar. That's all. This is a multiplanar external fixator. It's called the common as Elizarov circular external fixator. This can come in your exam. If you see this, if you comment it as this is an Elizarov multiplanar external fixator, if you say those words, you are done. And you do a proper examination, you are 5 out of 5 marks. Okay. So when do we do surgery in fractures? Because this could become as MCQ point. That's why I put these things. Indications for surgery in fractures. For fractures that is unsuitable for non-operative methods. For example, a neck of femur intracapsular neck of femur fracture. There's a high chance of avascular necrosis of the head of the femur. This is a common MCQ. You should know this. So non-operative management is not suitable. It needs fixation. If the patient is mobile previously, if that patient has been walking before the injury, then it should be fixed. Open fractures need open surgical intervention to reduce, because there's already wound. There's no point of doing manual manipulation and anesthesia. We can just go in and fix, and we can do a wound debridement at that point. Failed non-operative management. We have tried with conservative management, like skin traction and POP cast, but it's failed. So we need to intervene. Pathological fractures, as I said earlier, we need internal fixation. Intra-articular fractures. As I said earlier, it needs very accurate anatomical apposition. Otherwise, the joint function will be affected. So for that, we need excellent reduction and fixation. Fractures involving growth plate definitely will need surgery. Otherwise, the patient will develop growth retardation and limb discrepancies. established malunions and non-unions. We have tried with the patient. Basically, the bone has not healed properly. So we need to go in and actively intervene. We need to trim off the bone segments and fix it. Evolution fractures. Okay, complications. So what are the general complications of fractures? Hypovolemic shock. For example, a fracture in the shaft of the humerus. The thigh can hold up to 1.5 liters of blood, and that can cause significant hypovolemia in a patient, almost grade 2, or between grade 2 and 3. So of hemorrhagic shock. So we need to do so that can cause hypovolemic shock, because for example in fracture of femoral shaft, fat embolism, the bone marrow has fat. So when there's a fracture, these small fat particles can get dislodged into the arterial supply and get carried in the venous supply and get carried and get obstructed in the lungs. It's called fat embolism, usually present in 2 to 3 days after the injury. Crush syndrome. If there's associated crush syndrome, there's associated soft tissue injury. Massive soft tissue injuries can cause crush syndrome, where the muscles get necrosed and those the muscle toxins are reintroduced into the blood supply, and it can cause systemic side effects such as myocardial dysfunction, acute renal failure, arrhythmia. The patient is coming to us after 5-6 days of an injury of a compound fracture. The patient will be may come with infected local site, early complication. If it's for example a pubic fracture in the innominate bone, again hip bone of the hip bone, it can cause visceral injury to the rectum, into the bladder, into the prostrates, into the uterus, into injury to the small bowel. Visceral injury. Vascular injury, for example, one of the most notorious is supracondylar fracture of the humerus. Can cause vascular compromisation, vascular injury, nerve injury. The same injury can cause median nerve injury. Compartment syndrome, as we mentioned earlier, the trauma causing inflammation, causing edema, cause compartment syndrome. Infection, hemorrhage, gangrene, gas gangrene, because if the patient comes with delayed presentation and there is a clostridial peripharyngeal infection going on, it can cause gas gangrene, accumulation of gas in the subcutaneous tissue causing crepitus. So, gas gangrene. Hemarthrosis, there could be bleeding into the joint cavity causing hemarthrosis, very painful. Local complication that appears late, delayed union, malunion, non-union, that we have already discussed. Muscle contractures, it could be ischemic or arthrogenic. Ischemic is when there's distal blood flow is compromised. There's ischemia to the muscle. Ischemia to the muscle causes muscle death. The myocytes myocyte does not reproduce. If they die, that is healed with scarring, and this scarring causes contractions. It's called Volkmann contraction, especially in the hand after supracondylar fracture of the humerus. Volkmann contraction. If we don't appreciate it fast and do active intervention, it can cause Volkmann contraction. Arthrogenic. If we hold POP cast for a long time, the muscles tend to get stiff in that position. Arthrogenic. Tendinitis, the tendons can get inflamed due to sharp edges of the bone consistently irritating the tendon, can cause tendinitis. Joint stability and stiffness. If there's a fracture involved in the articular surface, joint is not stable, unstable. And stiffness, if prolonged immobilization, it can cause ankylosis, joint ankylosis. Avascular necrosis of the bones, very notorious in neck of femur fractures, intracapsular neck of femur fractures, especially in the elderly population with very trivial falls and osteopenia. Females are very prone to get neck of femur fractures, need active intervention. Scaphoid fractures at the wrist, again scaphoid fracture at the neck, can cause the distal proximal segment to cause avascular necrosis because the blood supply in scaphoid is retrograde. It basically goes down and come up. So the proximal segment gets necros. You don't need to know these. These are just for completion sake. If you know neck of femur fractures, artery integrate avascular necrosis, scaphoid fractures, talus neck fractures, that is more than enough. You don't need to know where the fracture, which segment gets necros. That is for higher PG education. You need to know there's chance of avascular necrosis in this is fracture. That's all. And pressure ulcers, because the patient will be mobilized for longer periods, it can cause pressure ulcers. Simple. So that's it. So there are some. So these are my references for this lecture. And there are few questions. This we need to do it together. So I'll give you 1 minute. So you try it. I'll give you 2 minutes because as in exam setting you will have 2 minutes for question. So you read the question and put your answers. Either you can put in the chat group or you can label in a paper of you and then you compare with my answers. Okay. Question 1. True or false regarding compartment syndrome of the lower limb? Absent pedal pulse is a late fee. Okay. You answer first. I'll give you 2 minutes. Okay. True or false regarding compartment syndrome of the lower limb? Absent pedal pulses is a late feature. Yes, as I said earlier, the arteries tend to be compressed at the last at the last feature. So absent pedal pulse is the last feature to develop. That is true. Affected limb should be elevated to relieve edema. What do you think? Is it a good idea or not?
False.
Yes. Why is it false?
So then, relieving edema, there are other things that we should worry about.
Yeah, like what?
So to release the pressure inside the compartment, it
Yes.
takes time.
Yes. Yes, you are absolutely correct. And the most important reason is if you elevate the limb, so if there's already compression of the arterial supply, the gravity also helps to take some blood beyond the point of compression. The gravity also. But if you elevate the limb, what will happen? We will take off the gravity factor. So there's some degree of less blood flow going to the distal segment if you elevate the limb. You got the idea?
Yes, sir.
Yeah, so that is the main reason. But what you said is also correct. All 4 compartments in the leg need to be released. That is true. As I showed you earlier in the image, all 4 need to be released. Numbness in the first dorsal web space of the foot is an early sign. It's not the earliest sign, but it is an early sign. It will come as the second sign, because as I said, the first web space is supplied by the deep peroneal nerve. The deep peroneal nerve comes through the anterior compartment, and when there's anterior compartment pressure, it tends to this nerve tends to get compressed earlier, and the sensory loss will be an early sign. That is true. Undue calf pain at passive extension is an early feature. That is true because out of proportion pain at passive extension of flexor muscles, because flexor muscles are the bulkiest muscle. If you take your body, just have a look, the flexor muscles are more bulkier than the extensor muscles. So the bulkier muscles get stretched, and these flexor muscles are stretched at extension. So this muscle that is already edematous and inflamed, when we stretch it, it causes pain. Right? Okay. All right. So I hope everybody got the answers correct. Okay. Question number 2. True or false regarding fractures? Just take 1 or 2 minutes and answer. Okay. True and false regarding fractures. Chronic osteomyelitis can cause pathological fractures. Is it true? Yes, it is true. Green stick fractures are common in children. Is it true? Yes, it is true. As I said, I mentioned earlier, the in children the ossification is not yet complete. There are still a fibrocartilageous element in the joint, so that is elastic. Those fibrocartilage element is elastic, so it can handle stress without being fractured. Non-union of fractures is a cause for pseudoarthrosis. That is true. Pseudoarthrosis is where a fractured a fracture after an malunion, it tends to work as another joint. So basically the fracture ends are not stable. It is healed with fibrosis, but it can move with each other. It acts as a joint, a non-functional joint. So it's called pseudoarthrosis. Yes, that is true. Soldiers are known to develop stress fractures, yes, because of their march past, because they are marching all most of the time. They can develop structure, and they carry a lot of heavy weights all the time. So the basis of stress fracture is application of a stress over prolonged repetitive stress over a prolonged time cause the bone to weaken. That is the principle. So soldiers are known to undergo stress, uh, repeated stress for long period of time. So they can cause stress fractures. Vertebral column is a site for compression fractures. Yes, the torus fractures I was talking about. Those are the fractures. Okay. Question number 3. 34-year-old man came to A&E with Gustlow 3B compound fracture. So if you remember what is Gustlow 3B, compound fracture with a tissue loss wound more than 10 centimeters, and the soft tissue cannot be approximated. There's soft tissue loss, and it cannot be approximated to cover the bone. Tibial fracture with gross contamination, no vascular injuries. What is the most appropriate method of stabilization? So this is an SBA. So what do you think? Internal fixation, POP with a cast, skeletal traction, skin traction, or external fixation? It's a young fit gentleman. So we should try to, as soon as possible, get this patient back to his functional state. So what is it? What do you think? Anybody? Any idea? Shall I ask somebody? I know I also hate when lecturers ask separate people. So I won't ask. Anybody? If so, yeah, there's a gross contamination, and internal fixation is out of the window, gone. POP cast. Somebody has answer. Yes, that is true. Yes. Yeah, so internal fixation is out. POP cast with the window. It is, yes, it is one of the methods that can be used, but not in this patient. This is a young gentleman, 34-year-old man. But in this patient, it's better not to, it's not the most appropriate. It is one method of stabilization. It is a method, but it's not the most appropriate in this patient. Skeletal traction, no. Skin traction, no. There's no point. So the answer is external fixation. 46-year-old man present with closed fracture of tibia 5 hours ago. He has numbness of his toes and pain on movements of toes. Distal tibial pulse was present. What is the next best step in management? I think this is very easy for you, even with the lecture. So anybody want to answer? Yes. Jayawickrama. Yes, you are correct. We need the urgent fasciotomy because this is compartment syndrome. This needs urgent release of the compartments. That needs a urgent fasciotomy. Good, very good. Another question. 28-year-old male following an RTA was brought to the A&E. He was having a compound tibiofibular fracture with significant tissue loss of 10 centimeters. Which of the following method is best to replace the tissue loss? flap repair, healing by primary intention, healing by secondary intention, split skin graft, secondary suturing. Anybody wants to answer? So what type of fracture is this? Anybody? Castillo classification? 3A. No, it's not 3A. Yeah, 3 is correct, but more than 3 is 3B because significant tissue loss is there. So what they're implying is they won't be able to close this tissue. So it's actually 3B, but you got it correct. 3 is correct, yes. So what do you think the answer is? I know this is this actually this principle we did not discuss in the lecture. So in
So
a
C, healing by secondary intention.
yeah, thank you, Shankar. Is a management option, but the problem is healing by secondary intention. This is a compound fracture, and this can cause healing by secondary intention will take a longer period. And the other problem with healing by secondary intention is now the bone is exposed to the external environment. There's a risk of developing what you call osteomyelitis. So healing by secondary intention is not a good alternative here. Healing by primary intention is not possible here because we can't approximate the tissue together. So healing by secondary intention is a little bit out in this actually because we need to cover the compound fracture somehow to prevent osteomyelitis after initial wound debridement and after giving some time. But healing by secondary intention is not a good option. Anybody? D, split skin graft. Split skin graft. Now this we are going to we are trying to put a skin graft over a compound fracture with the bones underneath. And in this case, in this case, it is not possible because split skin. If you try to define what split thickness skin graft is, we are basically taking the epidermis with a small part of the dermis, the papillary dermis. Okay, so that is a very soft piece of tissue, which will most likely will not hold in here. So the best method is by a flap repair. So we take a either myocutaneous or cutaneous flap. It can be a free flap. That means we can take it from another side with a vascular pedicle and attach to a nearby vessel to the wound, or we can do a rotation flap. We can take a flap near to the wound and we can rotate it to the wound to close it. So the best is a flap. I know that I have not discussed this principle with you in this lecture, but in this case, a flap repair is the best method to replace loss. Because healing by primary intention is not possible because of the tissue loss. Secondary intention is not possible. We can give it will try to heal, but there's a risk of developing osteomyelitis. So it is not an ideal option. Split skin graft is unlikely to take on the split skin graft. The chance of accepting the wound is less. And secondary suturing is again basically like healing by secondary intention, and it's not possible because of this significant tissue loss. Is it clear? Do I need to explain this principle more? The principle is we need to cover the bone to reduce the risk of osteomyelitis. In order to cover the bone, the best is to put a cutaneous flap where there is a skin and fat and sometimes even muscle also, which acts as a good barrier against infection. Putting just a split skin graft, the chance of it getting rejected is high. Understood? Yeah. Jayawickrama. Very sorry. You have answered correctly. Very good. Sorry, I didn't say the message. Yeah, that's what I said. These messages I won't be seeing because I need to go and tick it. If you just on your mic and just say, it will be easier. That, but very good, Jayawickrama. Superb. Okay. So I hope all of you got the answers correct. Question 5 is a little bit advanced, but this is a question from a local university final MBBS paper. So these kind of questions can come. The principle is basically that if you know the principle, you can answer, you can bet as they bowl. That is not a problem. Okay, so that marks the end of our lecture. I hope you got a good idea about what are the principles of fracture management and how to evaluate a patient with a fracture. And I hope my lecture was actually very clear. If you have any doubts, you can just put a message if you are unhappy with talking, or doesn't matter if you just on the mic and speak. If you have any doubts regarding this lecture, usually after a lecture, the most lectures ask whether there is in questions, and the most common response is silence. I hope the silence is because you understood the lecture, not because you are afraid to ask. If you did not understand this lecture, don't feel afraid. You just ask. Nobody knows your name. Nobody sees your face. Just ask the question. It doesn't matter. We everybody asks. I also sometimes ask my consultant stupid questions. No questions is stupid. Every question is valid because there's a reasonable doubt for it. So you can ask any question, not a problem. Nobody is going to criticize you. If you have any question, just ask. Okay. Anyhow, in future, do more questions. Thank you, sir. Okay. We'll thank you for the feedback. We'll address that definitely. Thank you, Jayawickrama. Anybody else have anything? I know that you are coming here after your routine lectures, and you must be tired also. And thank you for all of you guys for listening to this lecture for so long. I hope it's very clear for you. Okay, then if there's no questions, admin, shall we then finish the lectures? Sahansi, thank you. Yeah, thank you, sir.
Thank you, sir.
Okay. All right then. All the best to everybody. Have a good night. And just before you go to sleep, just try to make a short summary of what we discussed today before you go to sleep. Take a in the if you want to, you can make a small note, or even in your mind, just reconcile repeat what we said, and just make a small summary. That will help. If it's better if you can write it down. Okay then. Have a good night then.